So I think we'll make a start, and a very, very warm welcome to you all in the room and also online. I think we've got a few people online as well. So welcome today to this session about scaling up a health systems interventions, lessons from the Perform to Scale project in Uganda, Ghana and Malawi. My name's Joanna Raven. I'm from the Liverpool School of Tropical Medicine in the UK, and I'll be chairing this session today. So I'm a researcher as well. So why are we looking at Scale Up? Why have we all appeared in this room? So while many strategies have been developed and tested to improve equitable access to healthcare, the challenge remains in how to sustain and scale these innovations such that they result in universal health coverage. There's insufficient evidence has been paid to the science of scaling up so far, including how to address the factors that determine whether an effective intervention can be successfully scaled up or not. Two key factors include power relations or dynamics and politics, both of which affect if an intervention is prioritized for scale up, if the necessary financial and human resources are allocated, how scale up is implemented, and how effective the intervention is at meeting its objectives over time. So in this session, we'll describe how a management strengthening intervention implemented at district level has been scaled up in the 3 countries. We will look at how the different stakeholders, policymakers, implementers, researchers, have worked together, or not, to scale up the intervention. And finally, we will look at the methods applied to document this scale-up process. So we have a great lineup this afternoon. Here in the room, we are delighted to have Dr. Joseph Okware. Give us a wave, Joseph. No, he's the Director of Health Services, Governance and Regulation at the Ministry of Health in Uganda. We have Olivier Onvlee, a researcher from the KIT Royal Tropical Institute in Amsterdam. We have Kingsley Chikwapulo, a researcher from Reach Trust in Malawi. Give us a wave, King. And then online, we have Dr. Bongani Chikwapulo, Head of Norms and Standards in the Malawi Ministry of Health. And we're hoping to have Dr. Patricia Akweongo from the School of Public Health in University of Ghana. Is she here yet? Yes, she is. Great. Great. So we've got a full house for our team. So let me just explain what we're going to do today. So we're going to have an introduction to start with, where I'm going to explain a little bit about the Perform to Scale project and the MSI, or the Management Strengthening Intervention, and our scale-up approach. Then we're going to have a couple of lightning talks from the policymaker and the implementer. Then we're going to do a human spectrogram. Then another couple of lightning talks from researchers, and then end with a Q&A session. So please keep your questions, jot them down as we go along. And if you're online, please put them in the chat and or the Q&A section of the Zoom meeting. So let me first introduce the Perform to Scale project to set the scene. So from 2011 to 2015, we did the Perform initiative, which is where we tested a management strengthening intervention that took a systems approach to addressing workforce performance. We did this at district level in decentralized contexts where district health management teams may have more space to make decisions and act. And this worked, basically. But the program was conducted in 3 countries and covered 3 districts in each country. So, however, to have a greater impact, the Perform initiative needed to be scaled up, hence Perform to Scale. We love our acronyms. So, the Perform to Scale is funded by the European Commission's Horizon 2020 program and finished in after 5 years in June this year. These are our partners, lots of partners there, and another picture of us looking quite happy. And the main aim of this program was really to learn about scaling up, using a tested and wanted intervention, which we referred to as the Management Strengthening Intervention, the MSI. So let's have a quick look at this intervention. So the Perform MSI is based on the following principles. The district health management teams, or DHMTs, choose the problems to address, as this increases ownership of the whole process. We didn't provide extra resources for the work plans that they developed. And this is often a challenge in the context of lots of donor funding, and we'll probably discuss that later. Not being too ambitious with plans so that strategies are feasible. The primary objective of this was learning, was strengthening the management teams to learn from their processes. But this takes time, and it takes time over a number of cycles. Carrying out the intervention as a team, so using the skills of the whole team of the district health management team. And this also mitigates the problems of turnover to some extent. Strong facilitation skills of the resource team and the country research team to guide and support the DHMTs. Not always the natural habitat of us researchers. And finally, this is the really important one as well, sharing and experiences and learning across the districts. So this is kind of the management strengthening intervention, and it's based on the core principle of learning through action and reflection. So initial visits by the CRT, country research team, and short workshops at the plan stage, with further visits and inter-district meetings during the implementation period, are designed to help facilitate the DHMTs through the MSI cycle. So of plan, act, observe, reflect, and away we go again in the same cycle. And the total length of one MSI was approximately about 10 months. As DHMTs go through multiple cycles, they managed to, that increased the depth of learning. So one cycle didn't work on its own, the second cycle and the third cycle, learning, strengthening management as we went along. So that's the MSI. I just want to talk to you about a little bit about the approach for the scale-up that we took. After reviewing a number of options, we chose the ExpandNet, which is a WHO scale-up framework, and adapted it for our use. So here it is. So the first bit, and I'm going to just talk through a few of these aspects of it. First bit is the innovation. What are we going to implement? And it was the management strengthening intervention. The second area is the National Scale-Up Support or Steering Group. And their role was to manage the scale-up process, taking key decisions on locations during the project period and developing the strategy for expansion, including securing resources beyond the project end, and also to select and manage the resource team. And the resource team, the role of them was to gradually take over the facilitation of the management strengthening intervention in new districts. The context was critical, so we selected decentralized settings where we thought there would be greater decision space. And then obviously monitoring the context and looking at the context throughout this process where there was lots of changes, political changes, organizational changes, and of course the dreaded COVID. Our focus was to build the infrastructure to carry on the scale-up. And there are two components of the scale-up strategy. The first is about the horizontal scale-up. So this is the expansion of the MSI across districts. And the teams developed horizontal scale-up plans at the start of the project. And the second is about the vertical scale-up. So this is the scale-up where where you want to institutionalize the MSI into policies and structures. So it incorporates the concepts of handover and funded absorption of the MSI into structures and policies. And the final area I just want to talk about is the research bit, covering the process and outcome evaluation, covering the following research questions. So we looked at the context, so we carried out an initial situation analysis on the stakeholders and experiences of scale-up based on reviews, reflections, and key informant interviews. We went on to do process evaluation, looking at the implementation of the MSI itself, as well as the process of the scale-up, largely using qualitative methods. And then the outcome, looking at the effects of the MSI and the scale-up process and the costs. So a lot of work there. So that was what we kind of planned. So what happened in practice? The really interesting bits now coming up. So I now want to hand over to my colleague, Dr. Joseph Okware, to talk about the scale-up journey in Uganda. So welcome, Joseph.
This is the pointer.
Yep.
Okay, good afternoon, everyone. Good afternoon, members here, and good afternoon, the colleagues online. Thank you very much, Joe, for that introduction. I am happy to be in Bogota. I didn't think I would make it. I came from another meeting in South Korea, and it was quite a long journey. But I'm happy I'm here. My name is Joseph Okware. I'm a doctor at the Ministry of Health in government of Uganda. So that's at a national level, as you could imagine. But I was part of this whole intervention that Uganda benefited from, together with the two other countries and that Joe has just talked about. My role in that consortium or in the intervention were really two roles. The first one was to coordinate the National Steering Group, which was formed at the Ministry of Health for scaling up of the MSI management strengthening in Uganda. But the other role was to provide general oversight of the implementation and scale up of perform to scale. But today I was requested within 10 minutes to really focus on the challenges, focus on the challenges and the facilitators that we had in this process of steering in the scale up process. That's one. But also the other aspects that Joe talked about, institutionalizing the MSI, either the whole of it or part of it, into policy and into practice in Uganda. After all that had been done in all these years, as the government of Uganda, Minister of Health, we had a responsibility to pick out either the whole of MSI process and put it in our policy and practice, or if we don't do that, then we would have wasted everybody's time. So it was a big challenge. So I will begin by just describing the process a little bit. What we did, we had to identify the levels of governance of the health system that we're going to operate with or operate under. We identified at national level, we identified and formed a structure which we called the NSSG, the National Scale-Up Steering Group, of very, very high-level people at the ministry and the government of Uganda. Then we had, and you can read the membership there. Sorry, we had a second group of the technical working groups in the ministry, and then a third level, which was the district health management teams. Uganda has a decentralized form of governance. We have 136 districts, and each district has a DMT, and these were really the people that implemented the initiative. So the national level team were very, very highly placed people and very busy people. But this is what we agreed with Makerere University that we collaborated with in implementing this initiative. And then the second level was formed of highly technical people, the assistant commissioners. These are people who really run the technical aspects of the health sector. And then the third structure was the country research team. This was mainly from Makerere University School of Public Health. And the fourth structure was the technical working groups. Again, these were part of the governance structures of the Ministry of Health. Then the other most important structures were the DHMTs that Joe has talked about, but also the regional quality assurance and quality improvement committees at a regional level. Now, speaking to the challenges that we met in the process of implementation, definitely there were many, but I'm happy to share with you that even at national level, we had quite some challenges. As I had told you in the beginning, we really aimed high. We wanted an NSSG to be quite involving the Director General of the ministry, involving the permanent secretary, myself, who is a director, and a few other people. And we wanted them to guide the process of implementation and pick the good things in the MSI implementation as we go. But however, this was not possible. They didn't function as we envisaged, because in our plan we had indicated that they would be meeting twice a year, but we later found out that for them to meet only 2 times a year was very, very irregular, and they were not making much impact in terms of guiding the implementation and following what we were doing. Also, the officials were very high level and busy people with very many other national priority programs, so they didn't really give a lot of time to the work that the teams were doing. The other challenge with this group was that we later found out that the structure of NSSHG that we formed seemed to be running parallel to already existing structures. So this is a lesson. When you intend to scale up an initiative, it's better to use the structures that exist already. Because as you go high, people do not want new structures on board, because already their time is taken up. Because already we had a senior top management committee meeting that sits every month, and we could have used this structure to inform them on what we're doing, other than creating a new structure. So we quickly adapted on this, and by some good luck, I was selected as the focal person for this intervention, and I'm a member of Senior Top. So we reduced the other committee to a smaller one, and I took on the responsibility of updating the NSSG on what was going on, and they appreciated that approach more than having to call them for a breakfast meeting or for a separate meeting altogether. Then we had another challenge on the other structure, which I told you was very technical. The other that structure, the RT, we still had a challenge there because these are technical people and they are likely to be transferred from one ministry to the other. And this happened for us in Uganda quite often because we had, within the RT group, we had officers like human resource commissioners who are transferable from ministry to ministry. So actually, as fate had it, there were member of the HR, the resource team, the commissioner HR was transferred to another ministry, and another one was brought on board. He was also transferred before the end of Perform to Scale, but we, luckily enough, were able to keep them, still even getting them from those other ministries and bringing them to work with us. And that's how we managed to get around it. We unfortunately lost, I think, 1 or 2 of members of this RT group, but we had new appointees whom we had to bring on board. The third challenge was with the concept itself. In Uganda, by the time we started implementing the MSI, we were already quite advanced in the QI process. And for some of you who are implementing quality improvement and quality assurance, we are using the PDSA cycle, plan, do, study, and act. And this turned out to be very, very similar to what MSI was introducing. So much as we wanted to implement this according to the book and how it was introduced, we were quite often stopped along the way. They told us, no, but what you're introducing, we are already implementing, and we have resources for this. We have already scaled this up throughout the country. What is the new thing that you're bringing? So we had to fall back a bit. We did not dispute that, but we had to find the new things that MSI was bringing in on board, and we merged it with what was going on. So as you can see, those are many challenges indeed, but they are also facilitators. I don't know whether you can read that, but we had quite a number of facilitators that helped us. Our ability to constantly engage with the structures of the ministry, especially brought about by the fact that I was a focal person and I was a member of top management. I was able to create an engagement with any level of the Ministry of Health structures anytime. So that helped. Then we adopted one good principle that came with the MSI, that's reflection and adaptation, and that helped us. We also had time on our part. The timing of implementation of MSI was very good for Uganda. This was a time when the sector was rethinking the approach of delivery of services from the national level delivery to a regionalized aspect, way of delivery of services. So we got on that and we helped the country to develop regional teams, which were supposed to implement both MSI, but also implement implement quality assurance. So then there were a lot of flexibilities also, and this was around when COVID was coming on board. So we had to learn to use other ways of sharing information and making sure our point is taken abroad. So finally, we did achieve quite a bit from this process of MSI implementation over the years, because one, the quality improvement using the PDSA approach was mainly focusing on service delivery indicators. Improvement of coverage, those were the kind of problems that the teams at the district were identifying. Very few of them were able to focus on indicators that are going to improve the performance of the human resource. But this MSI approach enabled us to cause them to begin thinking about things like late coming to place of work and things like absenteeism. Using this approach, a number of teams were able to engage and improve their work. And also, when we worked with the ministry on the regionalization and strengthened the regional teams at all the 14 regions, we were able to make that process move faster and provide evidence that it works better. So government of Uganda adopted it, and also the partners adopted it, and eventually now we have all the 14 teams very strong, and they're getting funding from partners like CDC and USAID, and we are proud of the regionalized health system today. So far, that's the scale up is alive, and it is moving on fine with challenges, but I must say that yes, we did achieve quite something from this. Thank you very much.
Thank you, Joseph. Thank you very much, Joseph, for those really interesting journey of scale up in Uganda. And in particular, the points I wanted to bring out there was using the existing structures, the technical working groups, seizing the opportunity of a policy window, finding the niche, and the different language that you have to use to be able to convince people to scale things up. So really great. Thank you very much for that good start to it. Let's, you had one more slide, but never mind. There we go. So let's move on to Malawi and Dr. Bongani.
All right, thank you very much. Good afternoon. And it is evening in Malawi, past 9 o'clock in the evening. My name is Bongani Chikwapulo. I'm from Malawi, working with the Minister of Health in the Department of Quality Management, and I'll be sharing the lessons. So Malawi is in the Southeastern Africa. For those that have not visited Malawi before, it is 12 flight from South Africa. The country has got 5 health zones, and in each health zone, we have got 4 to 5 districts on average. Perform to scale was implemented in 3 zones, and in each of the zones, it targeted 3 districts. Please move to the next slide. So towards the end of the perform to scale, we developed a scale up strategy, and this strategy was endorsed by the National Steering Group. The strategy had 3 elements. The first one was to use the quality management zonal officers to facilitate the scale up. So for the zones that were already engaged in perform to scale, their role was to facilitate scale up to the other districts that were remaining in that zone. And for the 2 zones that were not part of the initial implementation, the zone officers were oriented on the management strengthening intervention so that they can facilitate implementation in the district under them. The second element was to integrate element of the situation analysis that we're using into the integrated supported supervision tools that were used for supervision by district health management teams, and this was done. The third element was to integrate the adapted principles of the management strengthening intervention within the zonal quarterly DHMT meetings. As of now, the integrated supported supervision tools are being used in all districts, and which is a big win. For the zonal quarterly DHMT meetings, unfortunately, they're not happening as regular because of financial constraints. We're still exploring ways on how best we can be able to leverage resources from other programs, because we still feel that the senior management teams at the district can benefit from peer-to-peer learning and group coaching done by the Ministry of Health. Next slide, please. So a number of facilitators that enabled the scale up. The first one was the initiative was in line with the strategic vision of ministry in improving leadership and management at all levels of care, and also in line with the quality management strategy. The MSI, as it has been pointed out by our colleagues from Ghana, was already similar to the QI methodologies that we're using in country. The initiative was so strategic because it was targeting district health management teams that are responsible for provision of secondary and primary services. And these services constitute about 99% of the services that are being provided in the health sector in Malawi. The other element which was quite important was the involvement of the local government. In the context of decentralization, they provided credibility to this initiative, both at minister level and also at the at district level, because Minister of Local Government is a policy holder of decentralization policy, and the management strengthening initiative intervention provided a platform for the local government and Ministry of Health to provide real-time guidance in terms of implementation of decentralization in the districts. The other element which was quite which was important was the functionality of the RT. Initially, it was a fixed team, but over time we realized that we needed to be flexible because the district were having different needs, and we needed to be flexible to ensure that we are able to provide the required support as demanded by the district. As of now, the RT coordination has been decentralized to the quality management zonal offices. The other elements, which was so very crucial, is that we had political buy-in from the senior management with all the leadership strengthening initiatives that were being implemented in country, and this also enabled successful scale up. So our story would not be complete without pointing out the challenges that we met during implementation, and also some of the challenges that are persisting. So when we studying the initiative, there were different school of thoughts in terms of which department is supposed to coordinate this initiative. As you are aware that leadership and management interventions are quite cross-cutting. So others had the opinion that it has to be under human resource. Others were thinking of planning. Others were thinking of the clinical directorate. But at the end of the day, a decision was made that it has to be coordinated by the quality management directorate because the department was already implementing similar interventions to promote leadership, and the intervention was also in line with the QI methodologies that were being championed by the department. The other challenge that we also made during implementation in some of the districts was movement of high turnover of some DHMT members, and which affected implementation and scale up in those districts. The other point is that decentralization is still evolving in Malawi. It has not matured. There's still gray areas. As much as the initiative provided a platform where the local government was providing guidance, but there's still difference between what is on paper and what is being implemented. And decentralization is still maturing. The other element is the role of the zone in the decentralization context. There are also different school of thoughts. Others feel that the zone have to be abolished with decentralization. But I think we thought that the zonal structure is still strategic because it is a decentralized administrative structure of the ministry. It provides a linkage between the ministry, the central ministry, and the district, and it is closer to the district to provide the required technical support. The last challenge, which is very important, is limited funding going towards leadership and management intervention. To make a case for support for leadership intervention has not been easy, and we still exploring ways on how we can make it we can make it attractive to partners so that it is funded. For the case of Malawi, I think it is not, we don't have a choice. We need strong leadership to maximize the little resources that are in the health sector. And in the new health sector strategic plan, which is running from this year to 2030, one of the key reforms is to align partners, having one budget, one plan, one M&D, and this will require strong leadership at all levels of care to ensure that the partners are aligned to the vision, because we have a lot of support coming from partners, and to align them is not easy, because not all the time that unfortunately not all the time partners will have interests that are in line with the government vision. So for us to be able to align them, we require a strong leadership to be able to achieve the healthy goals for Malawi. Thank you. Over.
Oh, thank you, Bongani. That was great. So lots of different points there about the timeliness of the intervention fitting in with things going on within the country, the importance of going wider than the health sector, the local government and other donors, etc. But the challenges there with where to put the MSI and the scale-up process, the sort of power dynamics between directorates, and how do we talk with people? How, that in the plenary about being diplomats, wasn't it? And about how to talk politically. This is coming out here loud and clear, isn't it? So let's move on. The human spectrogram. Time to move, everybody. Time to move. So, first of all, everyone stand up, okay? And within this, we've got agree over there, disagree over there, and really a line between those. And what I'm going to do is I'm going to make some statements about scale up, and I want you to position yourself on this imaginary line between agree and disagree, okay? And then I'll come to a few of you and ask you, why have you put yourself there? And when you hear that, you might think, well, actually, I might want to move now. That's a very convincing argument. I'll start moving. So please do, okay? So first of all, let's have a go. Scaling up a public health intervention is more a technical process with less to do with politics. Agree or disagree? Agree is over there. Disagree is over here. Ooh. Thanks. Is it on? Yep. Good. Oh, we've got a real swell over there. Now, you can have different degrees of agree. You could be just here. Anybody just here, or are you all the way over there? Agree and disagree. Okay, I'm going to come over here, and I'm going to ask, does anybody want to explain why they've positioned themselves there? First of all, any hands up? Go on. Go on. Hey.
Thank you. Jen Olson, I'm with JSI. The point about decentralization is extremely well taken because I think it really is an evolving nature in a lot of countries. So trying to move with something that's already moving can be a huge challenge. I think of it a lot like, how do you stop a top from spinning? You really can't grab it because it's always moving and changing. So that's what I think of about politics.
Okay, good. Anybody else want to explain why they've positioned themselves there? Ooh, yeah.
Well, I'm positioning myself here. Of course, I don't deny the political dimension of scaling up whatsoever. I apologize for my voice. But I see that in all the scaling up, programs don't take the responsibility for the technical issues of scaling up, which are fulfilling the conditions that they were fulfilling in the pilot period. Conditions in time and in technicity, capacity. They take shortcuts, and the political will is used to cover their own failure. Sorry to say.
Okay. Anybody else want to comment on these things? Yeah, please
yes. In the case of Senegal, half is transferred competencies to the local government units. And to scale up approach at decentralized level, you have to play the game with the politicians, which is the mayors or the council at the local government units.
Okay, good. Any other burning points on this one? Yes, please do.
So I just wanted to add that scaling up itself is a technical process. Like there are political dimensions to cover, and that's not said. But scaling up an intervention in the pilot phase is totally different from when it's been scaled out. There are different technical elements as well to consider, to rethink and to revise as well. So I'm in the middle because it's you need to rethink that too.
Okay.
I think for me, scaling up a public health intervention means we're going to need more money, which means we're going to have to engage with the politicians. And so that's why I feel like it's more, actually, I think the technical process is equally important as the political processes.
So do you want to move?
Oh, okay.
Does anybody else want to? Oh, hang on.
Thanks. I think that just to add one bit of nuance, maybe scaling up, effectively scaling up a public health initiative, because when you're scaling up, obviously you need to consider context, and what worked in the pilot district may not work in the next district. So I think that side needs to incorporate the technical side as well in order to effectively scale up.
Okay, great. Oh, another point? And then we'll move on to another statement.
I just want to add that I don't think politics is only with politicians.
No.
That there's a lot of politics in the system with operators in the system, and a lot of that is what needs to be managed in the technical scale up to get people to take up new activities. So that's kind of why I lean more politics, not politician, but internal politics.
Yeah, good. Okay, let's have another go at another one. See what happens then. Okay, you shouldn't start with the scale-up process without being absolutely sure about securing funding for scale-up. Ooh la la. So agree and disagree. Oh, we've got a bit of a mixture here. I know it is. Yes, it is a difficult. I don't think I framed it very well, but yeah, it is. It's good, isn't it? We do actually. I won't be presenting them, but yeah. No, they're in a report of ours, so I could share that with you. Yeah. Oh, yeah. Okay, let's see. Who wants to explain where they've positioned themselves? Oh, yeah.
Yeah, thank you, Bruno Boucher from Chemonix International. If you wait to secure funding for scale up, you will never scale up. So you have to, how do we say, build the boat while sailing, or your wings while jumping from the cliff, or something like this.
Okay, lovely. Now, I think there are a few people here that might disagree with that statement. Do you want to explain yourself?
Thank you very much. My name is Antonio Fosu. I'm from Ghana. I think I look at it basically. I mean, you want to cook a meal, you don't have enough money, then you start. I mean, you will get stuck. Because the pilot is the proof of concept. So that is what you're using to prove concept and get funding to scale up. And if you're not able to do it, I mean, why you get stuck.
Okay.
Yeah.
Okay. And, oh, yes.
So I think I might be a bit confused by the double negative, but I guess I've been battling a little bit with what a public health intervention is, because there's a big difference between a leadership intervention, as you were discussing, and a new program of some variety. But for a sort of leadership intervention, you're never going to have enough money, but you shouldn't stop. Even if you don't have enough money, you've got to make it work within the system, because leadership development's important.
Thank you. Very good points.
And if we're talking about definitions, the other question is, what are we talking about a scale-up process? Because you're not going from one district to all districts, or one province to one province, like from a Monday to a Friday, right? So there are smart ways to say, okay, we didn't get all the funding we wanted from from implementing a pilot in one area, right? But maybe you're going to be strategic in terms of, okay, we have particularly influential people who are working these other districts. We're going to scale here and then see if we can move forward. So that's my take.
Thank you. Any other points for this one?
Hello, Marine Vignon, Alima. I think that the process of scaling has to start from the beginning, but the process has to start without the scaling up. And if there is no start point, we cannot scale up anything. But the scale up need to start at very, very early stage to be successful.
Yeah. You start with the end in mind, don't you? Yeah. Okay. Have you got energy for one more? Yeah? Okay, good. Let's see what this one does. Agree is over there. Agree and disagree over here. Doesn't matter. So evidence versus engagement. Or is it sitting on the fence? That's all right. Okay. So we've got a lot of agreement here. Anybody want to explain their position? Oh, disagreement, sorry. I'm getting muddled up with my slides. We've got a lot of disagreement here. Anybody want to explain their position? Yep.
I'm Christian Auer from the Swiss Tropical and Public Health Institute, but I was not involved in this project. But I think both, I mean, if you don't engage stakeholders, you can basically forget it, right? but I think it's not ethical to promote an intervention if you don't have the evidence. So that's why for me both is very important.
Hello, Lara Vaz with the Population Reference Bureau and Momentum, but I do think that knowing what evidence is required for the stakeholders to engage is really important in then designing your studies to build the evidence and also to present the evidence. Thanks.
Hi, I'm Julia Watson from Abt Associates. And isn't there something about timing in there as well? You don't do, yeah, if you haven't got the evidence, then engaging your stakeholders, but I'm not saying that you have to wait to engage stakeholders before you start. I'm not quite sure exactly where I sit on it, but I think there's a timing, there's a timing issue, a sequencing issue or something.
Okay. I think we're going to have to stop this, but it's very nice, actually, this method. I rather like it. But we have to move on to the next couple of presentations and hopefully have a bit of time for questions and answers. So thank you very much for yeah, good. Okay, we'll have that at the... okay, let me just... That was my other one. Anyway. Okay, now we're going to Ghana, and I invite Patricia. Are you there, Patricia?
Yes, please.
Oh, good. Okay, we're just going to set it up so that you can you see the slides? Yet?
Yes, I can see the slides.
Okay, good. So maybe you can start and then tell me when you want me to move the slides. Okay?
Okay. All right, so thank you all very much. I'm Patricia Akweongo from the School of Public Health, and I'm presenting this on behalf of the team from Ghana. Next slide. So Ghana, we started the implementation of the management strengthening intervention in one region. That's the eastern region of Ghana. And we started with 3 districts, and these 3 districts were selected based on the league table. They had a performance table of districts. So in 2018, we selected a high-performing district, middle level performing district, and low-performing districts. So they selected a strategy and implemented in 2018. And then in 2019, they tried another strategy after they had successfully implemented the first one in 2018. And so we had a second group of districts and then a third group of districts. And so these are the districts that we worked in for the last 4 or 5 years of the project. And this is where the location of the Eastern region is. Next slide. Okay, so we had a regional scale-up support steering group as well as a national scale-up steering group, because we realized that at the regional level we had a strong team of directors, and as a result of that, they supported the implementation of the scale-up, and also because most of these regional directors would sometimes end up at the national level as directors. So we thought there would be a great group of people who could support the scale-up if they happen to be at the national level. And also because the regional directors also meet every weekly and monthly at meetings, so they are able to share their ideas and to support the implementation of the strategies. Next slide. So with the implementation of the MSI, districts that were participating in the intervention were trained in how to identify a problem within their district, how to develop a strategy, how to implement. But as Joe mentioned earlier on, the project did not give them extra funding for the implementation of the management strengthening intervention. So districts that selected a strategy that required resources beyond the district, decided we had to look for other sources of funding. And so the innovation came in because most often, apart from the national the national immunization days, where they actually got in touch with district assembly, they didn't realize that even strategies that had nothing to do with national scale interventions, they could also source for funding. So they got engaged with other businesses outside the health sector, including the water company, the banking sector, to support the implementation of these activities in terms of training, providing them with logistics and finances to implement their strategies. Next slide. So as a result of implementing the management strengthening interventions, we had experiences from some of the individuals and districts that understood the MSI process very well, and they were able to link up with other regions, and even at the performance review meetings, they were able to demonstrate the performance indicators, how they had improved their performance indicators for the strategies that they took. And so because of that, they were able to share the MSI with other districts at that level. And also apart from that, they also became the resource team, because of their level of understanding, the level of implementation, and the improvement of the indicators in their districts. They served as resource teams for other new districts that were coming on board. And they also were so critical in terms of networking within their district and other districts to support the implementation and the dissemination of the successes of the interventions that they were actually implementing. Next slide. So there were a number of adaptations that were made during the scale-up. One of them was during the pilot, we realized that there was a conflict in terms of the schedules of the DHMT members and the implementation of the MSI. So there had to be an alignment with the district planning cycle, so that they could actually pick strategies, implement them within their planning cycle and without disrupting any activities. And then we also realized that there was a lot of staff turnover in the districts. So we decided to involve the sub-district level because we realized that they were more stable. So in terms of sustainability purposes, we actually introduced the workshops, the MSI workshops at the sub-district level to train the sub-district team in how to identify a problem, how to select a strategy, and how to implement a strategy and assess and reflect on it. So going back to the reflection was one of the key tools that the DHM used. And this was to enable them monitor and observe what was in the implementation of their SMIs, whether it was going on well, where the challenges were, where to re-strategize. So we decided to integrate a reflection tool as part of the activities that they had to do frequently. And then one other adaptation we made was the fact that we had to introduce regional level officers as part of the resource team, because we also realized that for sustainability purposes, that engaging the regional officers actively in the process would strengthen the implementation at the districts or at the regional level. And then we also realized that due to the staff turnover, we had to retrain DHMT members anytime we had new members joining the team. So these were some of the adaptations that we used to make sure that the process could be scaled up without much disruption. Next slide. Okay, so thank you. And this is what we want to share from the implementation that we did in Ghana. Thank you very much.
So thank you very much, Patricia. That was great. Lots of different points there about engaging with other sectors for funding, adapting the structures for scale-up, and adapting the MSI for scale-up as well. So finally, we've got the last lightning talk, and I mean lightning now. So Olivier, over to you. Thank you. I'll leave that.
Thanks so much, Jo. Yeah, now last speaker, and now it's up to me to talk a bit about research methods or how we sort of approached evaluating scale up in this consortium. And it's quite a complex intervention, not quite as complex as hosting a hybrid meeting, but close. So I want to talk a bit about that. Yeah, as I said, my name is Olivier, I'm with KIT. KIT has the great role of evaluating actually scale up in the consortium, and it's been a real privilege to do that. So I want to talk about 3 points today. So how did we approach scale up from an evaluation perspective? How did we try and understand the power in politics as part of the evaluation side? And what are some of the implications for researchers stemming from that? Is it working? Yes. So maybe to bring it back a bit to our beginning. So as a consortium, what we did is we actually, at the very beginning, created a theory of change to guide implementation and research within our consortium. And as Joe's already introduced before, we use the ExpandNet framework to inspire this this TOC, and also some additional research. And what we came up with is this TOC. I won't go into it too much, but essentially we have a pathway on vertical scale up, we have a pathway on horizontal scale up. Then we map the outcomes that we expected in the 3 different spheres, so sphere of control, sphere of influence, and sphere of interest. And the little bubbles that you see are the assumptions that we work with. Now, this really helped us to sort of get a theoretical idea of what we're talking about, and we used that to sort of develop the different research tools and the studies that we used. So Joe's already introduced these, so we had an initial contact analysis, which is a bit more of a PEA study, or the process evaluation, and an outcome evaluation. And the interesting thing about this is that as implementation went along and we got these findings in, we discussed these in our consortium meetings, and we reflected on them, and we actually tried to help use these insights for implementation, for the scale-up strategies, but also we went back to the TOC itself and tried to see how can we maybe improve certain assumptions there, how can we refine our model. So I think that made quite an interesting model, TOC, which evolved over the years, and I think there's been 3 or 4 iterations now. And that also brings the interesting point that how was research really used in our consortium? Well, for multiple things. So it's research for the sake of research, so understanding scale up, but certainly also for implementation. And that's something that we really like talking about, and we wrote a very nice paper on this, so I won't go into it too much, but it's very interesting stuff. So briefly, I wanted to put the spotlight on one of these tools, so the process evaluation. We've done 2 rounds, one in person, one unfortunately due to COVID, half in person, half online, where we essentially tried to understand both horizontal and vertical scale up progress and how it's done. We did this by doing in-depth interviews on the MSI, which is really at DHMT level, trying to interview the DHMT members and also local political leaders. And we did a scale-up assessment, which was essentially sort of a ranked statement type of thing where we asked statements and asked responses to that and got very interesting discussions going on different matters. And finally, we also had the reflection sessions with the country research teams in order to really find out what worked here, what were factors influencing this. And we took all these qualitative data together, had a thematic analysis, and while I don't really want to go into our findings too much, I do want to highlight a couple of things. And especially also, I'm looking at my former speakers, there are a couple of interesting things that came up. And also, how do we differentiate the findings from the 3 different countries? Because there were very different outcomes. And then we found a couple of very interesting findings. So I think Bongani talked a bit about decentralization in Malawi, and decentralization, also the process of it, and sort of the confusion that was maybe still there. That very much influenced scale up. We talked a bit about, I think, the windows of opportunity that arrived in Uganda, where we looked at how can we make sure this happens. So what I'm trying to say here is that when we look at how can we explain these different outcomes, we see that they're very often very political. And here, I think I'm going to be preaching to the choir, but what really helped us to understand these different outcomes is applying political economy analysis to this. And we've had a lot of sessions this week on it, so I won't go into it too much, but we really tried to integrate into our research ideas of how do we understand knowledge, interest, power, and position of stakeholders. How do we also understand scale up, not just as scale up, but also as oftentimes a policy reform that needs to happen. So how do we understand this institutionalization, what is needed there? How do you understand all the different opinions and agendas that come out of this? And as I said, how do we help with this identification of windows of opportunity as they arise? As said, we did this in the initial context analysis. We also included a lens in the process evaluation. But what we also very much saw is, as a research consortium, just doing the analysis and just studying the studies wasn't really enough. We needed to go a bit further and actually reflect as researchers, how do we deal with this? If you get this information in, how do you deal with this? And also, very often, you don't have this information at hand. How do you make politically sound decisions, sometimes at a moment's notice? So what we started focusing on within our consortium is this idea of thinking and working politically. So bringing it a bit further than just the analysis, and also really, kind of going for a best of both worlds approach, where we both used the research findings from political economy analysis, but also try to see how we can empower our colleagues to also, make snapshot decisions within meetings, how to improve scale-up strategies that were developed, and all these sort of things. And this is by no means, this is very much still something that's difficult to do, and this is a learning process for us. But we found that it was a very nice thing to do, and I think there was a lot of positive feedback on that. And it also helped us to think a bit about, this idea of researcher positionality, especially in these sorts of projects. How are you engaging with that research, and what is then also your role in the implementation? And how do you deal with that? How do you get forward? So to kind of give a small example, and I realize I'm building on some of the experience and some of the frameworks from some of the people in this room right now. So I just wanted to give some examples of what we did. So we had consortium workshops. We had a lot of online webinars because of Zoom, because of COVID, where we tried to use interactive methods, such as Mural, to sort of map stakeholders in this process of policy reform or policy integration in the different countries. So we tried and see, who are your interest groups, who are your external actors that can influence this. And I think it was quite nice. We had some webinar series on political economy analysis, trying to, see what do we mean by this and how do we do this. And I will round it off because I know that there's a lot of discussion, but I will finalize by saying something I heard in one of the sessions yesterday, and that was one of the people, when people were when people better understood what PEA and thinking and working politically was, they also recognized that, in many ways you're already doing this. We're all doing this. We're practitioners. It's just being perhaps also a bit more aware of it and using it proactively. So I'll stop with that because I know there's a lot. But, thanks.
Brilliant. Thank you very much, Olivier. That's great. Thinking and working politically. We all do it. We all need to be more aware of how we're doing it as well. So we have 15 minutes for questions and answers. So I'm going to ask the panelists to come to the front here. Come and sit down here. Yeah? And I would like to have Bongani and Patricia on the screen as well. And I'm going to can you hear me? Open it out to you all to ask questions to our panelists, please. So come and sit up here. Bring these out from behind the thing. Okay. Have a seat. Okay. Any questions then? No? Ooh, come on. Yes. So we have one for there. So should we just take 3, and then we've got 4. Okay, we'll take those 4, and then we'll open it to the online panelists. And there's none there. Okay. It's all yours, everyone. Okay, go ahead.
Thanks so much for such a great panel and really wonderful presentations. I don't know if this is a fair question, but one thing I noted, Alison Lipsky, RTI, sorry. One of the things I noted is that a common success factor cited was timeliness of the intervention. My question is, did the timeliness factor come into country selection before? I'm thinking of the alignment with donor timelines, right? And how we're often trying to meld the relationship between donor timelines and in-country local stakeholder timelines and how those things interact, speaking of politics. And so I'm wondering if you can shed any light on terms of that timeliness dynamic, and if it wasn't part of the country selection process, what were lessons learned in maneuvering that, in country, I guess, or navigating that dynamic in country? Thank you.
Lovely. Thank you very much. We'll take 4.
Thank you very much. My name is Akweongo, I'm Apt Associates. I just have a quick question for Dr. Joseph. Was there evidence that the MSI scale-up effect that you found in Uganda built on the existing PD Plan, Do, Study, Act model that the folks at the regional level said they were already implementing, albeit that the results they already had, like you said, was more service delivery focused? And then was there some, like, an additive effect of this work on that? So did we have even more improved service delivery type outcomes because of this management type interventions that this QI process introduced? That's my question. I had a second one for Ghana, but let it go around first.
Okay. Another question was...
Sorry, here also? Sorry. Hi.
Sorry.
Peter Peterson, Dublin City University. Actually, I have a very kind of a similar question. I'm just particularly interested in what sort of practical changes were made in management through this process, and I kind of wonder also, like, how does this intervention kind of changes this level of adaptation? Was there anything that you hadn't thought of, or was it just not part of the former practice? Just kind of keen to know what inspired you, given it was a local-led intervention as well, in terms of the actions that kind of made you include certain actions that were successful.
Thank you. And one more, and then we'll brace yourself, panel. Are you getting ready?
Thank you. It's Kai Heath from Oxford University Population Health. I'm interested to learn a little bit more about the dynamics of the consortium. I'm particularly interested to know if there was any exchange of ideas between the different countries that were involved, because it sounds like you're all at slightly different stages, and so I wonder whether that community of practice in effect sort of helped you all to move along your scale-up process.
Lovely. Okay, so we've got timeliness of the intervention. Question about that. We've got a specific question for Joseph about evidence of MSI scale-up built on PDSA results, practical changes in management during the process, and dynamics of the consortium. Who would like to go first? Joseph, you've got the mic.
Okay, thank you very much for the questions. I have been involved in quite a number of interventions, and I am as confused as you are. I could have asked the same question if I was in the audience. But for this particular experience that we have gone through with MSI and Perform to Scale, I want to believe that many times the opportunities actually exist, but they may not be known to you in the beginning, depending on how you approach, how you enter, depending on the entry into a system or into a country. When starting up a program like this with an end in mind to change policy, you need from the word go, from the beginning, to engage with the high-level structures that are available. They are the ones that are likely to know that in 3 years' time, a certain framework or a strategy is going to require review. So it will provide you an opportunity to input your evidence which you intend to generate. But if you don't have that in the beginning and you start low, probably with teams that may not know what is going to happen, then you will not prepare for it. The opportunity will come and you will miss it. So for our case in Uganda, we started high, and the teams that were going to review the strategic plan for QI were in the know, and they were able to inform this team of Perform to Scale that, look, this resembles the QI strategic plan, and in 2 years, we're going to review the plan. So if it is successful, then we should be able to have an influence on this. So the important thing here is that those opportunities exist, but you have to look for them. They can just pass you and you find that you've missed everything. That's my view about timeliness versus opportunities. Opportunities are there, but you have to search for them. They will not come knocking to you. Do I answer the second one? Or okay, on the second one was the issue of MSI, scale up versus the PDSA. Again, already we were implementing PDSA for quality improvement and quality assurance. And as I told you, the way it was introduced through donator support, and which were disease specific, USAID and others, and they had interest in HIV, TB, malaria. So this philosophy was introduced with the objective of changing those indicators. So when it was rolled out to the regional and the district level, the teams were sort of guided to choose improvements along those service delivery indicators. And yet, it is also important to change the human resource. So when we brought up MSI on HR, this added on to what they were already doing. And as we rolled out the MSI approach, we noticed that there was one thing that was unique, that as you do MSI, you had to go through a lot of reflection and thinking, and then before you finally act. So this is one new thing that we added on to our new strategy and framework for Uganda that we formed after the MSI implementation with Perform to Scale.
Thank you so much. So in terms of timeliness and opportunities, I'll give you a perspective from Malawi. We actually saw the opportunities and we seized them. We had 2 opportunities. So the quality management policy had just identified leadership and management as a key gap within the country. Similarly, the National Health Sector Strategic Plan had also identified leadership and management as a big issue. And so the coming in of Perform to Scale for us was actually timely. Added to that, we had made entry visits to the ministry. But like you heard Bongani presenting, the politics within the ministry is what kind of diluted the whole thing, right? And they made it seem like it wasn't a timely intervention, but it was due to their own, political battles within the ministry. And for us, it was actually quite unfortunate because we had already reached agreements with other directorates within the ministry. Actually, a very influential figure, actually, Okware. And then only to be told no, okay? And actually, one thing that Bongani didn't mention, we were actually also referred to actually a technical working group from the ministry. Now, somebody from the ministry says, no, actually, you know what? You have to go and present to the HRH technical working group. Those are the ones that can actually advise you. So we spent like a whole year, moving up and down because of these politics. And I think that was quite unfortunate for us. And so indeed, I'm not surprised to see people getting an impression as if it wasn't all that timely. But I think it was timely, and we see the opportunities that were there. It was just unfortunate. In terms of the practical takeaways, I think that we see the intervention brought, I'll give you some examples from Malawi. We saw DHMTs actually realizing and calling this intervention as an eye-opener in terms of decision making. There was, in one district, a district hospital had gone for, I think, 5 years with a very critical equipment in the theater. It was damaged. And for 5 years, they had been requesting the ministry to support them, you know, fix this one or procure a new equipment, and nothing happened. But when we brought in this intervention and highlighted to them, shared them some skills on how they could actually maximize on the decision space that they have as managers at that level, they actually realized that within the meagre resources that they had been complaining about all these 5 years, they could actually save and rectify the problem in the theater. And they made a resolution to say, okay, out of these budget lines, let us save here, let us save here, let us save here. And within 6 months of this project, they fixed that project. Meanwhile, they had been, you know, stranded for 5 years. And so we thought that was a big win for us. And they actually said in their own words, to say, I think this is an eye-opener. We never thought we would actually sit around the table as managers at this level and make such decisions. We were always waiting for the ministry to come and, you know, do it for us. So I think that's one big example that I can give. I have a couple of them, but I think for the sake of time, I should hand over.
Yeah, I'll keep it very short because I know that the colleagues in country may actually be able to say more about this. I don't know too much about the timeliness because I joined the consortium late. What I will say is, like, to what extent can you plan for the right timing? We've had COVID, we've had so many things come our way. How do you do that? So I think it's perhaps more an importance that how do you recognize the moment you're in? How do you use that? How do you adapt your communication strategies to that? And how do you make the most of that? I'm not sure if we did with COVID. I think perhaps we could have made more of it and we could have used it better. But yeah, just a very quick reflection. But I think Dr. Bongani and Patricia.
Yes, Dr. Bongani and Patricia, please do you want to add to any of those questions? And the one we haven't answered yet is the dynamics of the consortium and the exchange of ideas across the countries. So I can see Bongani making him not mute. Go ahead, Dr. Bongani. Any comments? Oh.
Nothing at this point.
Okay. Patricia, anything to add to any of those questions about practical changes in management or the dynamics of the consortium?
Yeah, so I think there were quite a number of practical changes to management because through this project, they were able to think outside the box. And then as Malawi pointed out, they were able to use those skills to really get resources from non-health organizations like the banking sector and like the water company. Because for instance, there was this health district management team that did not have water for the ANC clinic for over close to 9 months, and yet they didn't identify that there was that water company in the district that could support them. And so when they went to the district, the water company, they got a storage tank. In addition, they were getting water regularly for their antenatal clinic. So in terms of really changing their mindset and how to use their decision space to support the activities of the DHMT, that is one of the added values of this particular intervention. Thank you.
Thank you, Patricia. Anybody want to answer this question about the dynamics of the consortium? I think they're a bit unwilling. The exchange of ideas across the countries. I think there's quite a few examples of that.
I think Olivier touched on that as well.
Okay.
So I think the consortium meetings actually provided us that opportunity to interact as a consortium, and more especially the reflections that we took on our own theory of change. For me, I think they were actually a big learning for us. You know, so like conducting self-evaluation as you go along, and I think that is critical, and it is important, I think, in implementation research kind of projects, so that you don't wait up to the end. And it actually accorded us the flexibility to adapt, you know, and respond to forces on the ground. So I think that actually put us all on the same footing as consortium members. So we were all learning from that process, and I think we really learned big. And the webinars that we had as a consortium also, they kind of helped a lot. So you might be aware, I think sometimes in consortia, there are always issues of power dynamics, you know, but when you come together like this, it acts as a platform to address all those, and you are all at an equal footing, and I think it is really helpful.
Thank you. Now we've got one question online.
Okay, we have a question from Nolifar, a QI advisor at FHI 360, saying, I found that when we implement, scale, and sustain local stakeholders that work with us, they often know the political dynamic, and we rely on their knowledge. It's fluid, and it seems that it requires that local network and reputation to build political will. What is the role of these improvement political champions in the system?
I think the participant is very right, and we discussed that a bit already in the presentation. Champions are very important at all levels. So in introducing anything new, you want to recruit as many people from within to sell the idea. It's not enough to just collect evidence and believe that that evidence is going to be taken to whatever level. No, you need the people to understand that evidence and take it in good faith, own it, and share it with the other stakeholders at different levels. And just to add on that, even the champions should not just come from politicians alone, but even from the other structures. For example, this particular intervention, I think, benefited a lot in that this evidence was being produced, the work was being done and produced through collaboration of universities, and people trust more sometimes the evidence that comes from universities. For us, we had already collaboration with Makerere University, which was collaborating with, which was a partner in this. And so they had a listening ear for every level when they said there is some evidence that has come up, and was able to penetrate through the stakeholders.
Now, I'm aware we've gone over a little bit, so I just wanted to give Bongani and Patricia a chance to give any final points that they wanted to say. Go ahead, Patricia.
Yeah, so in terms of the consortium, the project was set in such a way that we had to go to each country to learn from the experiences from each country, and as a result, they were set up in such a way that each country, you had a chance to go to a country, you had a chance to meet their policy makers, their stakeholders, to interact with the districts, and I think this offered us a lot of opportunity to learn about the context of each country and how our results could actually complement and be comparable in terms of strengthening the uptake of the intervention in the various countries. Thank you.
Thanks, Patricia. Anything to add, Dr. Bongani? Anything you want to say as a final word?
So maybe one thing to add, a lot has been talked about, but I think just to talk about the niche in Malawi. As much as the MSI was in line with the QI methodologies that we're using in Malawi, I think the target was unique because most of the QI support we were involving middle managers and frontline health workers, and the MSI involved senior management at the district level, and this was unique, and it actually introduced the QI methodologies at that level. The other element, I think, which is also very important, which we saw in the initiative, was the patience that the country research team had to be able to find a home for the initiative. I think working with the policy makers in country is very important for alignment of the interventions to ensure that the interventions that are coming maybe from elsewhere are aligned to the vision of the country. Thank you. Over.
Thanks, Bongani. So just some very quick and final points from me. Scale up is not a linear process. It's a bumpy road. And critical to this is having a shared vision of where you want to go. The scale-up process needs to be flexible to the context and adapted as you go through that journey. From the outset, we needed to consider how the intervention aligns with existing or new policies and interests. Evidence is key, but who provides that evidence, what that evidence is, how we provide it, the language that we use, and who receives that evidence, and what their position and mandate is, and how influential they are, is critical. And the final one was perhaps our biggest lesson that underlies all the other lessons, is thinking and working politically throughout the scale-up process. I thank you very much to all the panelists, Bongani, Patricia, Joseph, King, Olivier. Thank you very much. Thank you very much to all of you for staying on along this scale-up bumpy road that we've been on. Thank you for your participation. I hope you've enjoyed it. If you want to learn more about Perform to Scale, please do contact us. We've got a website. We've got lots of materials dotted around here. And come and ask us a few more questions. I know we haven't had much time for that. So thank you very much. And please go and have a cup of coffee.